Hi everyone, thanks a lot for your interest in this study. I'm Peter McAvoy, and I'm going to start us off talking about this Delphi study that we did to identify mental health research priorities. And this presentation in particular is about priorities for Aboriginal and Torres Strait Islander peoples. I want to start by first acknowledging the Aboriginal people of the many traditional lands and language groups of Western Australia. We acknowledge the wisdom of Aboriginal elders, both past and present, and pay our respect to the Aboriginal communities of today.
We also want to acknowledge the collective expertise of the people with a lived or living experience of mental health challenges. Equally, we recognise the important contributions that you all make and value your courage to share these unique perspectives for the purpose of achieving better outcomes for all of us.
So I'm going to hand over to Viv Chu, and that was John Braun, who did the acknowledgement of lived experience.
Hi there. So I just thought I'd start off with a bit of a background on the project and why we started this study in the first place. So basically, back in 2019, James Williamson and Darren Gibson, two people from over at Department Health, they recognised the need for a mental health research strategy in WA. So we've actually never had one before. And so we decided to convene a professional advisory group over in 2020 to start this work. And Pete and Ben, who are actually on this research team, then put together the Co-ROAMERS WA project. So Co-ROAMERS stood for a co-designed roadmap of a mental health research strategy for Western Australia. And then John and me got to join the team over in January 2021. So in 2021, we also convened a lived experience advisory group for the project as well. And then over February to September, we actually went about conducting the project and then also drafting the mental health research strategy.
So just starting off, thanks Viv, and starting off in terms of the engagement and consultations involved in the early parts of this project. The first reference group came together in November 2020, and that involved a whole range of people, health professionals, academics, lived experience individuals. We had meetings across the state with so for example, with CAMS, Greater Southern Aboriginal Health Service, Derby-Yerrigan here in the metropolitan region. We also made submissions to Aboriginal health planning forums across the state as well. And WAHEC, as most of you will know, we've yarned with Aboriginal leaders on the advisory groups, who I won't name, but we appreciate their engagement as well. And I think it's really important to mention that we referred to a good deal of literature available already in terms of policy and research documents written by Aboriginal people, researchers, academics, health professionals. Again, we don't want to and weren't interested in reinventing the wheel. And there was an awful lot of material that was incredibly useful in the early stages of the project. I'll hand you back to Pete.
There were some limitations to the consultation, which we will talk about a bit later. But we used the Delphi method to try and identify the mental health research priorities for Western Australians. And this process involves generating items. And as John just said, to generate items for the Aboriginal and Torres Strait Islander domain, we used all those reference groups and consultations and relied very heavily on existing literature that have already identified those priorities. We then administered the Delphi survey to expert panels, and we had two expert panels. We had a lived experience expert panel of people who were consumers of mental health services and also carers. And then we had a second expert panel, which was of mental health professionals. So that's healthcare workers, policymakers, and mental health researchers. And we were looking for consensus across both of those groups, and both were equally weighted rather than either of them being prioritised. We then collated and shared the responses with the panels, and they were able to update their responses, provide additional ideas, and before we finalised the consensus priorities.
Yep. So as John and Pete mentioned before, we did do a lot of consultations as part of our journey through this project as well. So we consulted with a lot of stakeholders just to try and understand the research questions and topics that actually matter most to people with either professional or lived experience of mental health challenges. We're not a team of just the 4 of us doing it all either. We had a great team of honours psychology students who actually helped out too. And they helped with reviewing the literature more broadly to help and develop an initial list of items for the Delphi survey. And this was extended across a broad range of mental health domains, which I'll show shortly. We also conducted an email call out throughout various mental health networks. And this was just to invite more suggestions on what potential mental health priorities or principles we thought should really be incorporated in the Delphi study too. We actually heard back from over 200 people in Western Australia, which we're really grateful for. This included researchers, administrators of health services, as well as non-government organisations, clinicians, policymakers, consumers, carers and peer workers. We then also recruited panel members for the Delphi study, and this started happening in about May to August last year. So basically, as Pete mentioned, we invited anyone who identified as a consumer, carer, or a mental health professional to sign up and complete the Delphi study. We also had hard copy versions of the Delphi surveys available too if people weren't able to complete them online. And as you can see from this slide, this is just a breakdown of what was involved in the Delphi study. So as Pete and John mentioned, we had 2 panels involved, one with lived experience, one with professional experience, and we conducted 3 Delphi survey rounds. Look, given the breadth of mental health, items were actually categorized into 23 different sections. So we had one which covered research principles, so how research should be done, general mental health questions which apply more broadly to everyone, and then specific mental health questions which are relevant to particular groups or topics. Panel members would then actually rate the research items on a 9-point scale, so it's basically rating from whether they felt the item was not important, important but critical, or critical. And they could also choose to provide feedback on the research items that were presented as well. Basically, after the first round, then panel, if we found that less than 70% of our panel members endorsed the item, then we would actually remove it from the Delphi study. Whereas if about 70 to 79% of panel members endorse the items, then we'd actually put it in a second round for re-rating. And panel members, where panel members, the majority of around 80% or more rated the question as highly important, we kept that in as a final priority for the study as well. And so this is our broad range of mental health domains. As you can see, there was Aboriginal and Torres Strait Islander domain, which John and Pete will speak more to as well in the results, and a whole lot of other ones. I guess it's worth mentioning also that there's a lot of intersectionality that can occur in the items as well. And so if you'd like to, you can refer to the final list of priorities as well, where you can see that intersectionality and where that really comes out as well in the themes too. I'll pass you on to John now.
Thanks, Viv. So I'll speak through some of the results that come out of this in terms of the participants and the panel members. We had 182 EOIs received, 120 took part in round 1 of the Delphi study. This was split into, as Viv's mentioned, a lived experience panel and a professionals panel, and not too dissimilar, lived experience with around 50-ish, professionals with around just under 70. The split in those is, well, for the lived experience, consumers were around, just over 2/3 of the entire panel. Carers were just under 1/3. In terms of overlap between the professionals and the lived experience panels, lived experience had formal qualifications in mental health roughly 1/3 of the time. For the professionals panel, split between researchers, clinicians, policymakers, and you see that again, excuse me, that there's around half of the professionals panel who also have lived experience as a consumer and/or a carer, which is important. And as Viv has noted previously, it was up to the individuals to decide if they had both, which group that they would end up being in. So in terms of demographics for the individuals who participated, you can see here, I won't read out all of the numbers, but the largest proportions are from multicultural backgrounds, LGBTQI backgrounds, alcohol and other drug issues backgrounds. If we look at the Aboriginal and Torres Strait Islander background, it's a little over around 5%, which is over the 3% population representation. So that's a decent showing there in terms of lived experience and the kinds of mental health concerns and categories within that. You can see here there's depression, anxiety disorders, PTSD, personality disorders, all the way to schizoaffective disorders. For the professional experiences, panel members, people from backgrounds pretty diverse, academics all the way through to psychiatrists, counsellors, policy officers, epidemiologists, etc. So a pretty broad bunch of individuals and disciplines. And I'll hand it over to Pete.
So across all the domains, based on all our consultations and literature reviews, we ended up with over 1,000 specific research questions. So it was a huge effort from our panel members to actually work through all of those items in the first round of the Delphi study across those 23 mental health areas. We asked everyone to rate the principles, and we asked everyone to rate the general mental health priorities, but all the other more specific areas were optional for people who felt they had an opinion or experience to guide their ratings. People could also in the first round offer additional potential priorities for rating, and if they did so, and 18 additional items were identified this way, they were rated in the second round. After going through 3 rounds, we ended up with 608 consensus items. 576 of those were research questions across those mental health areas, and 32 of them principles, which we put into themes, which you'll see on the next slide, and John will talk us through.
Thanks, Pete. So just briefly talking through the principles here, you can see there's a word cloud, I guess, giving you a general idea of the most important, or what were considered the most important. Collaboration is a big one. Co-design, you can see some of the principles that have been well documented and are becoming more and more well documented in terms of the research that is being done and should be done from some of the literature we've looked at. And if you work in the Aboriginal health space, I guess the narrative that is really strongly coming through there. We're talking about a values-driven way of doing it, so really important there. But really, I think importantly, that it's being recognised as the whole of person approach, a holistic idea of what individuals require and what makes individuals healthy beyond just very, very singular approaches to mental health. Some of the principles specific to research with Aboriginal and Torres Strait Islander peoples are noted here, but translation's a big one. Translation that benefits Aboriginal people, and this goes back to the idea of co-design and fundamental engagement very, very early on in the research process. Researchers needing to recognise that Aboriginal and Torres Strait Islander peoples have great strengths, creativity, endurance, and a deep understanding of relationships between human beings and their environment. And that's getting to that idea of the whole of person and a holistic approach. And taking into account culture is a really big one. Research projects should also build the capacity of Aboriginal people to do research. And this goes back to this idea of collaboration, co-design, but building capacity through that process, formally as well. And through that, we see the idea being that we see stronger translation and greater impact and sustained impact. And I'll hand it back to Pete for the next slide.
So we have a very busy table here, so I'm going to talk you through it and draw out a few main points. So down the first column here, we have all those areas, the mental health domains that we assessed, including the research principles at the top there. The second column is the number of items that were within each domain in the first round of the Delphi study, so quite a lot. The third column is a number of final priorities in each domain that were that achieved consensus across our lived experience and professional panels. So both groups agree that these were a high priority. And you'll see that the domains with the most items that went into the survey tended to end up with the most items. So domestic and family violence, mental health conditions, Aboriginal and Torres Strait Islander mental health had the most individual items. The next column reports the means or the average ratings for each domain. And one thing to notice is that they're all pretty closely rated in terms of their means. The margin was very narrow across all of them. And we all know that there are a lot of priorities in mental health and a lot of work to be done. So it's not terribly surprising that's the case. If we look at the ranking based on the mean ratings, you'll see that across the Delphi panel, the highest rated domain was Aboriginal and Torres Strait Islander mental health. So it was a recognition across the community, both the lived experience and professional community, that this is the #1 mental health research priority for Western Australia. The second was perinatal mental health, the third being clinical pharmacology, fourth, psychological therapies, and sexual trauma and unwanted sexual experiences. I'll hand over to John.
Thanks, Pete. So if we're looking at the top 10 mental health research priorities here, and if you really, and it's across 2 pages here, so, and maybe Pete, if you can click to the second one as well shortly. But a lot of this is really speaking to not just, well, what needs to be done, i.e. responding to self-harm and suicide, which are obviously no-brainers, but really the most effective ways to improve understanding, or the most effective culturally appropriate forms. And that question really pervades these top 10 areas. And I think that's encouraging. I guess it's really foregrounding that question of, okay, we need to know the ways to do these things. We know that these things need to be done. And that suggests a couple of things. And one of them is that organisations, and given the demographic of people who've responded to this, so not just Aboriginal people, but organisations are recognising that they don't know what are the best ways to do it, and they need to understand what they are to be able to provide that. And of course, this is the whole point of this research in many ways, is to find those things out and then establish which areas we fund them. So it's quite encouraging. I won't speak too much more to it, Pete. We can move to the next slide.
Yeah, so in terms of with the research priorities that shone through as well, because we had so many, we also decided to do a qualitative analysis to start applying some themes to the priorities that were coming around. So we ended up identifying 14 different themes. And this slide here is just looking at the themes that actually emerged specifically within the Aboriginal and Torres Strait Islander mental health domain. And so we can see that over 50% of the items are related to prevention, early intervention, detection and health promotion as well. And also really the great thing to see was the second most highest rated theme, which was looking at culture, spirituality and well-being and that sense of identity, and really just going back to all the research principles that shone through in this project as well about considering whole of person. And the other ones that were quite important is just looking at services, and as John mentioned, it's not just about making them effective, but really being culturally aware of these services and making sure that that they're responding to people's needs individually as well. And as I mentioned before, mental health is quite broad as well. So intersectionality definitely popped up as a theme as something that was quite important, that we're not addressing just one thing for an individual. Sometimes they might have a lot of different areas of mental health spanning over that we need to conduct research in as well. In terms of looking at the themes more broadly though, this is just a summary of all 14 of the themes and the mean ratings for across all the priority items that came up as well. So just to note, suicide and self-harm was, although they're all actually very similar, the highest rated mean was for suicide and self-harm, and this was followed by co-design, capacity building, and trauma and translation. And again, it's really just encouraging to see that co-design was one of the second highest rated means as well as capacity building, because it's really just recognizing that need for us to all come together with research and also just work towards with one another to build that capacity so that we can just achieve research that brings more benefits and outcomes more broadly for everyone in Western Australia.
It's really interesting that co-design also had the narrowest standard error, so there seemed to be a greater level of agreement across the group in terms of how important that is. So this is just a really brief summary about our findings in the study. So if people are interested in looking at a full list of the priorities, they're available at this website. We also have a preprint manuscript available if you'd like to read more about the study.
So just in a nutshell, I guess some of the learnings of our study. I'll start with some of the limitations, and there was a few areas that made things pretty challenging, and I think these have been challenges for a long time, and obviously with COVID in the more recent term, and they've been challenges for everybody. So COVID made things quite difficult. I think we set out to undertake this project at the worst possible time in human history, maybe. I don't know. The lack of engagement and recruitment in regional communities should be noted. A combination of travel restrictions, a combination of funding restrictions and time restrictions made it very difficult. As noted earlier, we reached out to organisations such as CAMS and in the Midwest and so on and so forth, and other Aboriginal community-controlled health services. Unfortunately, the limitations of this made it very difficult to do anything of meaning. I think going forward, that's something you would need to address. And of course, in terms of funding, they're the kinds of things you've got to take into account when you embark on a project like this, that working with Aboriginal community can take longer. In terms of a really key learning, well, it's not, again, I don't want to reinvent the wheel. It's not rocket science, but promoting social and emotional well-being among Aboriginal and Torres Strait Islander peoples is key. It's a key priority area for mental health research. Our mob have known this for some time, but it shines through in the research we're doing here. But it's multi-layered. It's doing research and being funded for research, being able to see it as a priority for research that where Aboriginal people can be involved in the promotion of this for our own communities, but also for services, Aboriginal or otherwise, to know how to do this and to be supported, at least in terms of resources, to be able to do it themselves. So it's happening from both sides of the coin.
So the results of this study really helped to inform the development of the first West Australian mental health research strategy. We submitted a draft of that strategy to the Department of Health in December last year. That was 2021. And we certainly from this study got plenty of evidence to support putting Aboriginal and Torres Strait Islander mental health as one of the three key priority areas within that strategy. So we would hope and expect that funders respond to that. We know that for the Future Health Research and Innovation Fund, First Nations mental health is an embedded priority, but other funders as well who are interested in responding to what the community of Western Australia believe are the priorities really need to consider Aboriginal and Torres Strait Islander mental health as one of the key priority areas for their funding. Researchers also may use the findings to help conduct research that meets the priorities identified by our lived experience and professional groups within the community. They may also use the findings to advocate for more funding in those areas of identified priority.
So thanks, Pete. So we know a bit more about what the mental health research priorities for the WA community are. And I think that's a nuanced message as well, because we should and do acknowledge that Aboriginal people and communities and health professionals and so on and so forth have been advocating for these things for quite some time. We acknowledge that 100%. What I think where the nuance lies is that we know that now, given the demographic, we know that non-Aboriginal organisations and health professionals, lived experience people are saying these are key priority areas. And that's encouraging. Hopefully that groundswell, enables a greater chunk of funding to be put towards these things. The great thing about that, addressing this next point, about building capacity to address as many of these priorities as possible, is the message that if you do things well in the Aboriginal space, the skills, the principles, etc., they're actually really good human principles. They address a whole range of issues and they extend beyond just an Aboriginal population. So it's a win-win in many, many ways. So where do we start in terms of, these priorities? Well, do we leverage existing strengths? These are some questions to ask. Do we leverage unique strengths? What are they? What will attract more national funding and co-funding to WA? What are the areas of most local need and what are the funder priorities? And there's a reciprocal loop in there somewhere. I think I mentioned in an earlier conversation about these, and that is, funder priorities will be shaped by what the strengths are, etc., but the strengths will start to shape those priorities. And I think we need to understand those really clearly to make this as impactful as possible.
So what was really helpful to us in identifying priorities for the mental health research strategy was not only evidence from this Delphi study, but also the advocacy work that John was referring to over many years by many Aboriginal elders and leaders in this space, whose work we rely very heavily on here. But the other thing that really helped us is how many leaders we have in Western Australia in this space in terms of researchers and clinicians. It is an area of strategic strength for Western Australia, given the capacity we already have in this area in Western Australia. I'm sure without even saying their names, we can all easily name a number of leading Aboriginal academics and clinicians and researchers in Western Australia. So we really want to build on that existing strength that we have in WA and embedding that within the draft strategy was one way of trying to leverage all those existing strengths. So in terms of the strategy, the other things we needed to think about was how we can build the collective gain across the sector, how we can build the partnerships and collaborations that would ultimately improve consumer outcomes. And one of the most critical ways is to prioritise consumer voices. Consumers know what is going to make the biggest difference to their lives, so we need to listen to that and respond to that. We need to build capacities for mental health research, not only in terms of engaging consumers and upskilling consumers so that they can optimally contribute to the endeavour and meaningfully contribute, but also healthcare workers as well need to ensure that they're able to contribute to research as well. We need to build the infrastructure and platforms that will facilitate these partnerships and collaborations, the co-design that we've already talked about as well, to promote those partnerships and collaborations and ensure that they can work effectively. We need support for research across the pipeline from burden of disease research so we understand the priorities, and I think we're at a point where we do understand a lot of the priorities. We need to understand the causes and effects, and again, a lot of work has been done in this area, but there's more to be done. Determinants of mental health and wellbeing, social and emotional wellbeing. We need to improve our efforts at prevention and intervention, so develop innovative and appropriate, culturally appropriate ways of preventing and intervening to ensure optimal mental health. And most critically, or at least as critically, we need to develop our translational research pipeline so that we know that what works can be implemented effectively and have an impact on the ground rather than just in particular populations. So as I was saying before, in the strategy, we're advocating for initially focusing on priority areas with existing strength, and Aboriginal and Torres Strait Islander mental health research is an existing strength and a strategic strength for Western Australia, given the leaders that we already have doing exceptional work. So it's an opportunity for us to really use that to leverage more national funding to build on that work and increase its impact even further. and rural and remote, and obviously Aboriginal and Torres Strait Islander capacities and strategic advantages we have in Western Australia really work together very well. So I just want to finish off with some acknowledgements for this work. Everyone who contributed at all stages through this work, it was definitely a community effort. Our professional advisory group, thank you for your support throughout this work. Our lived experience advisory group who guided us throughout the whole project from beginning to end, and the team who were tasked with really leading the work. I really want to acknowledge Ben Horgan, who was going to join us today, but unfortunately at the last minute was unable to join the recording. But Ben co-led this work from the very beginning. The Delphi study was his idea, and it was a pleasure to support him to be able to implement the project and get the outcomes we have. And to Viv and John as well, who were just key contributors to the whole project. Thank you as well. Okay, so we'll finish off this recording here. We have also recorded summaries of other aspects of the Co-ROAMERS project that if you're interested in, you're welcome to listen to as well. And we really hope you found this presentation interesting, and we really hope that the work has an impact. Thank you very much.